Okay, in this workshop, we're going to interpret data obtained from Swan-Ganz catheter or pulmonary artery catheter to see how we can use this data for the hemodynamic assessment of our critically ill patients. And the outline of the talk would be, first we'll present the waveforms of the catheter, talk about the indications, and then the accurate position of the catheter. And then we'll explain the thermodilution method to measure the cardiac output and see how we can wedge to measure the left ventricular and diastolic pressure. Then we have a couple of cases to see how we can interpret data obtained from Swan-Ganz catheter for the hemodynamic assessment in these two cases. So when we introduce the catheter and we reach the right atrium with the balloon inflated, we can measure the right atrial pressure. Keep advancing the catheter. We get into the right ventricle, indicated by the increase in the systolic pressure. And then we continue to advance the catheter with the balloon inflated to measure the pulmonary artery where the diastolic pressure is increased. And then when we wedge the catheter, we form a column that will give us an indication of the left ventricular and diastolic pressure, provided that we don't have mitral stenosis or regurgitation. The indications of Swan-Ganz catheter are mainly shock state with ARDS. However, with the thermodilution method or the transpulmonary thermodilution method by PICO can give us enough information to manage those patients, and I don't think we are doing Swan-Ganz for those cases, especially after the studies that showed Swan-Ganz do not improve outcome. The main indication would be in cases of right ventricular failure with shock syndrome or in pulmonary hypertension to guide therapy for the increased pulmonary vascular resistance. And post-cardiac surgeries and lung surgeries are usually managed with the Swan-Ganz catheter in place to assist in the hemodynamic manipulations for those patients. There are some contraindications to the insertion of the catheter, and these contraindications are absolute when we have tricuspid stenosis or pulmonary valve stenosis, if we have mechanical tricuspid or pulmonary valves, in cases of right atrial or right ventricular mass or thrombus, and of course in tetralogy of Fallot. Relative contraindication would be mainly left bundle branch block, as it may cause right bundle branch block when we insert the catheter. We need to pay attention that in order to get accurate measurements, the catheter should be in appropriate position, and it's in the area where the pulmonary pressure or the pulmonary artery pressure is higher than the pulmonary venous pressure, and both are higher than the alveolar pressure. And this is zone 3 of the lungs, which is the most dependent part of the lungs below the left atrium. On the chest X-ray, you need to make sure that the catheter tip is in the first 1/3 of the lung field, and the tip is directed to the base of the lungs. Let's see this video together to follow the insertion of the catheter and the different waveforms that we've seen. So after we inflate the balloon and the catheter is in the right atrium, we can measure the right atrial pressure here with the different waves. We introduce the catheter into the right ventricle, systolic pressure goes up, this is RV pressure, and then we advance it to the pulmonary artery, diastolic goes up, this is PA pressure, and then as we advance further, we measure the wedge pressure, and then deflate the balloon, goes back to the PA pressure, inflate again, we would move forward and wedge again and get the wedge pressure. At the same time, you need to
start a wedge
measure the wedge pressure, and the procedure to measure the wedge is essentially the same in all different monitors. You may have different windows in different monitors, however the principles are the same. Let's see this video together.
procedure. Select wedge to display the wedge procedures window. Prepare and check the pressure line according to your hospital policy. When performed, scale to optimum, as the resulting pressure waveform will fall below the lower scale. The accuracy of the wedge pressure relies on taking the pressure at the end of the respiration cycle when the intrathoracic pressure is fairly constant. When the monitor prompts you with this message, inflate the balloon. The waveform changes from the PAP to the PAWP wave. The measurement takes approximately 12 seconds. On completion, the monitor stores the PAWP waveform display and prompts you to deflate the balloon. To edit the wedge, select the Edit Wedge pop-up key to see the stored waveforms. The monitor displays a horizontal and vertical cursor in the waveform at the wedge pressure mean value. It also displays any previously stored value and the time it was stored. Move the cursors up, down, right, and left to set them on the correct wedge position. Select Store Wedge to store the PAWP value. Use Print Wedge to print the PAWP waveform and any reference waves, or Record Wedge to record them.
Okay, and next you would measure the cardiac output, and the procedure that you utilize here uses the thermodilution method. And essentially with thermodilution, 10 ml of normal saline is injected rapidly via the proximal port into the right atrium. The injectate mixes completely with blood and causes a drop in the temperature that is measured continuously by a thermocouple near the catheter tip. The area under the curve is calculated, and it is inversely related to cardiac output. So the higher the area under the curve of this thermodilution curve, the lower the cardiac output, and vice versa. So let's see this video together on the procedure of measuring the cardiac output.
In this section, we will demonstrate cardiac output monitoring using the right heart thermal dilution method. A fluid of known volume and temperature is injected into the right atrium through the proximal port of a pulmonary artery or Swan-Ganz catheter. The injectate bolus mixes with the blood in the right ventricle, and the change in blood temperature is measured with a thermistor at the distal end of the catheter in the pulmonary artery. With your thermal dilution circuit prepared, be sure the cardiac output cable is connected to the cardiac output module or the measurement server. Select the T-blood numeric. Confirm that the selected method is set to right heart, and check that the correct computation constant is entered in the cardiac output procedure window. If you need to change the value, select Computation Constant and use the pop-up keypad to enter the correct value. When you see this message, select the pop-up key Start CO. When you hear a ready tone and see this message, Inject the solution into the right atrial port of the Swan-Ganz catheter. The optimal injection rate is 2.5 milliliters per second. At the end of the measurement, the thermodilution curve, cardiac output, index values, and any curve alerts display. When you see the Ready for New Measurement message, repeat the procedure until you have completed the measurements you want to perform. You can perform a maximum of 6 measurements before editing. More than 6 measurements will cause the earliest measurements to be deleted. After completing your measurements, review them, especially any irregular trials or trials marked with a question mark. Consider the similarity of the values and the shape of the curve. A normal curve has one smooth peak and returns to the temperature baseline level after the peak. To reject a trial, select its trial curve. The background of rejected trials is red, and the background of accepted trials is green. The monitor will recalculate the average values after you reject trials. After rejecting any suspect trials, save the average CO values by selecting Save CO. This sends the average CO numeric to be displayed on the main screen and stores the averaged values in the trends and calculations databases. Select Print Record if you wish to document the cardiac output measurements. Choose Print Results to print the contents of the CO procedure menu. Record Results to record the contents of the CO procedure window, or Record Trial to send the most recent trial curve to the recorder.
So now let's discuss few cases where we can interpret the parameters obtained by the Swan-Ganz catheter for the hemodynamic status of the patient. These parameters are classified based on the preload, contractility, and afterload. Parameters that indicate your preload status are the stroke volume and the stroke volume index. You can also get information about the preload from the central venous pressure and, of course, the pulmonary capillary wedge pressure. Contractility is indicated by the cardiac output, the cardiac index, the left ventricular systolic work index, and the right ventricular systolic work index. And afterload, you can measure the systemic vascular resistance and the index of this resistance on the left side, and you can measure the pulmonary vascular resistance with the index on the right side. Historically, there is a classification of the Swan-Ganz parameters based on the cardiac index and the pulmonary capillary wedge pressure by Forrester in 1972, where they classified 4 different conditions. If the cardiac index is less than 2.2 with a wedge less than 18, this is hypovolemic shock and the patient would need volume loading. If the index is less than 2.2 and the wedge is more than 18, this is cardiogenic shock and the patient would need inotropic support. A case of cardiac index more than 2.2 and wedge pressure less than 18, this is a normal state. And finally, cases where cardiac index is higher than 2.2 and wedge pressure is higher than 18, this is a case of fluid overload. The patient needs to be on diuretics or vasodilators. With this background, let's just discuss the first case. 50 years old female, came to the ICU post-operatively at around 11 o'clock the night before. At 9 o'clock in the morning, she's on FiO2 of 50%. Saturation is 88% with a PO2 of 56. Mean arterial pressure is 64 millimeter mercury. Heart rate is 67. Lactic acid is 6. Patient received 500 ml of fluid bolus and the fluid balance is only around 300. Chest X-ray shows bilateral pulmonary infiltrates, as you see. and chest tubes bilaterally, 2 on the right side, 1 on the left. Swan-Ganz is in place and probably needs to be advanced a bit. However, parameters from the Swan-Ganz are shown here. And similar to the interpretation of transpulmonary thermodilution, I would start by assessing the preload first. And the preload is indicated by number 1, the CVP, which is decreased, the wedge pressure, which is less than 18, and the stroke volume index, which is decreased. So it looks like the preload is decreased. And as you know, if the preload is decreased, it may decrease the cardiac output and the cardiac index. And you see that here when we assess contractility, the cardiac output is slightly decreased. The cardiac index is 1.8, which is decreased. At the same time, you can take a look on the left ventricular systolic work index, which is decreased at 18, normal is 43 to 61. And also on the right side, it is decreased, it is 4, normal is 7 to 12. So we have indication that the contractility is decreased, but it could be because of the decreased preload. Now at the same time, the compensatory mechanism in the body with autonomic system will increase the afterload. So you can see here how the systemic vascular resistance is decreased, it is increased, and the pulmonary vascular resistance is increased too. And here we're looking at the index of the resistance. With this, this patient has decreased preload, decreased contractility, increased afterload. And the management of this patient would start with fluid. You need to replenish his intravascular volume and reassess the cardiac index and the cardiac output. If the cardiac index is still low, at that time you need to add an inotropic agent, and you assess perfusion, and you do this by looking at the lactic acid level. If the lactic acid is improved after volume and inotropic support, you continue monitoring. If not, you may consider to use afterload reducer. The second case is 50-year-old man, bilateral lung transplant 8 hours ago. Currently, he's ventilated and sedated. FiO2 40%, saturation 96%, PO2 67, and PCO2 45. Blood pressure is 103/57, mean arterial pressure 64. Heart rate 84, and chest X-ray. As you see here, you have Swan-Ganz, bilateral chest tubes, patient is intubated. Hemodynamic parameters obtained from the Swan-Ganz. And let's take a look on these parameters together. First, we need to look at the preload. The CVP is decreased, wedge pressure is decreased, and the stroke volume is decreased. So clearly, we have indications that the preload is decreased. Then you go to contractility. Cardiac output is normal. Cardiac index is normal. The stroke volume, as we mentioned, it's decreased. The stroke volume index is on the lower side. The left ventricular systolic work index is decreased. The right ventricular systolic work index is normal. So in terms of contractility, there's only slight decrease in the left ventricular systolic work index. The cardiac index, the stroke volume index are normal. And then let's take a look on the afterload. On the left side, you can see the systemic vascular resistance index is normal. On the right side, you can see the pulmonary vascular resistance index is increased, but this patient is status post lung transplantation. So if you want to put it all together, this preload is on the low side, contractility is acceptable, afterload is increased on the right side. Well, in patients post-operatively for lung transplantation, we like to keep them on the drier side. So it's okay to have slightly decreased preload if the contractility is okay. And for this patient, the lactic acid was 2.0 and the mixed venous autosaturation was 65, indicating adequate perfusion. For this patient, based on this hemodynamic profile, I would only continue to monitor and proceed to extubation. As you saw, the oxygenation and ventilation status are normal. With this, I would like to end this workshop and see if you have any question. You can add questions to the comment section of this video. Thank you.